My name is Jaysha Blocker Harris, and I'm a project associate here at SAMHSA Service Members, Veterans, and Their Families Technical Assistance Center at Policy Research Associates. And I'm grateful and have the honor to serve as your session moderator. Before we get in the weeds with all of the many things and all of the great information and hearing from our esteemed panel, I want to turn things over to our federal partners at SAMHSA and VA. And I will kick things over to Ms. Stacey Owens. Stacey?
Thanks so much, Jaysher. I appreciate that. For those of you who I haven't met, I'm Stacey Owens. I serve as the Military and Veterans Affairs here um, at um, at SAMHSA, and so glad to join you this evening for this webinar. As Jaysher said, we really wanted to take the time to amplify messages around expanding the conversation on lethal means safety. Here in the federal world, we think of things in terms of contract year, and we have about a week and a half left on the contract year. And our thought was, what was the final thought that we would like to leave governors and mayors challenge teams with? And we're in this really historic space where we have nationwide synergy with the challenge, and that's caused us to really take a moment to really put a critical eye through an equity lens. And we know that in terms of lethal means safety, there are a large number of suicides that are completed by firearms. But when we look at communities across the nation, if we look at people of color, if we look at women veterans, if we look at individuals who live outside of the continental United States, if we look at our kids, our military kids, our young service members, there are other means that we really need to give focus to as well. We've been really inspired by the work of the territories, the state of Hawaii, the Commonwealth that have joined us this year, and we've been inspired by you all to amplify this topic. Thus the choice of time, 5 p.m. for those of us on the East Coast of the U.S. We wanted to give the Pacific territories time to wake up and ask live questions if they would like to. So thank you for those of you who've joined us throughout the nation. And I will turn it over to my VA colleague, Cicely Burrows-McElwain.
Thanks so much, Stacey. It's lovely to be here with so many of you this evening. I'm blessed, as Jaysher is, and a couple of us, because we just got to do some amazing visits, and Chantel, to our Pacific territories and to the state of Hawaii, and just really wanted to reiterate this idea of part of the magic of the work we do in the Governors and Mayors Challenge process is listening to one another about where we need the education, where we need the technical assistance, and where, as I think federal partners, we could do better in supporting the delivery, the development, and the understanding of resources that are more relative to the communities we're working with. Often you, as the leaders in your teams, know best what you need from us. And so we're so grateful when you were able to share some of those needs and to elevate this work by finding 3 amazing speakers today that really have some great insights and successes in understanding how to look at lethal means in the way that they will be sharing with all of us today. I wanted to just, again, talk about the importance of this work and thank all of you. Stacey mentioned we're coming to the close of our federal fiscal year, but what that really means is we're coming to the close of another amazing 12-month period of time where your communities have come together and allowed us to learn from your work there on the ground, the innovations that you have underway, and also share with us the importance of what this work means to all of you, not only in your professional lives, but also our personal lives. Many of us have been touched by suicide in our personal and professional lives alike, and we recognize that this content can be really difficult for us to navigate, even when we have our very professional buttoned up hats on. Today, when we talk about lethal means safety, we always want to remind ourselves that the content can be something that can be at times uncomfortable, and we want folks to feel empowered to recognize when that content may be something that you may need to take a break from or to maybe ask some clarifying questions about what you're hearing. So please don't hesitate to do that. We have our whole team online, and we have the ability to do some great chats here with folks. If you have any need for reaching out for support, we want folks to know that we're here for you in that way as well. So I wanted to, again, just give the amazing thanks on behalf of all of the leadership here at VA for your continued support of this work. Please know that we are all ears when it comes to how we can continue to connect these amazing subject matter experts back to your teams. And thank you all as well for serving as subject matter experts to one another. Jaysher, I'll hand it back to you.
All right. Thank you so much, Cicely. Thank you, Stacy. All right, before we dive in, a few items to discuss. Our disclaimer, right? Please note that the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, and policies of that of SAMHSA, the U.S. Department of Health and Human Services, Veterans Health Administration, and the U.S. Department of Veteran Affairs. Of course, we want to ensure that this is an inclusive virtual meeting space. Please let us know your name and how you want to be called. If you have iPhone or computer by your name, please do change that so we can address you how you'd like. Please turn your video on if you are able to. We love to see your beautiful faces on this afternoon or this morning, right? Keep your microphones muted unless you are speaking. And please do use that raise your hand or chat function to communicate with the group. Following the presentation or once we hear from each of our prospective presenters, we will host Q&A. So please do use that chat function, note your questions, and we will get to all of those questions before we get started. Or after we're finished, after we're finished. Just following up on some of the words that Cicely shared with us, this is our trauma-informed approach. We want to make sure that during this meeting, you know that the content presented may be emotionally activating, and some as it discuss death by suicide, including means, manner, and method. And we just want to ensure that this environment is as safe as possible. Here are the 6 tenets from the SAMHSA's concept of trauma guidance. And we just want to make sure that we're providing a safe environment, number 1. We want to be open and honest during this conversation. Number 3, support others and seek support while we're having these conversations. We want to genuinely collaborate, engage. We are all here for one goal, and that's to reduce suicide in our nation, service members, veterans, and their families, and to learn how we can do that. And we want to choose how and when we engage with one another, empowering each other as we do this work. And number 6, we want to make sure that we're being cultural, historical, and any gender issues. We want to make sure that we are respecting and demonstrating inclusivity. All right. Session objectives. We're almost there, guys. We want to learn about research and work. We're going to learn about the work that's happening in Australia to prevent suicide in public places. We're going to learn about research related to overdose trends in military communities, and its correlation to death by suicide, including how the national opioid crisis plays a large role. And finally, we want to take a moment for our participants to have increased knowledge on what suggestions have been made in current research and suicide prevention strategies that address suicide by hanging or asphyxiation in community settings. So for you guys to do participant introductions, in the interest of time, please do let us know in the chat your name, your agency, your team. What team are you representing? Are you representing a Governor's Challenge or Mayor's Challenge team? And then, of course, what do you look to gain most from attending this webinar? We want to make sure we add that note, right? Just in case if there are items for future technical assistance that we might not address in this webinar, that'll give us some context and some clues on how we can possibly tailor our technical assistance in the future. So let us know in the chat. All right, and with that, guys, our featured presenters today, we will hear from Dr. Mark Larson, who is an associate professor at the Center for Big Data Research and Health. He's an honorary associate for the Black Dog Institute. Dr. Lawson is an associate, right? He is the chief investigator of the Center for Research Excellence in Suicide Prevention, in which he leads lethal means safety or means safety theme. He's also an associate investigator at the Center for Research Excellence in Prevention and Early Intervention in Mental Health and Substance Use. All the way from New South Wales and Sydney, Australia. We appreciate you, Dr. Larson, for joining us. Then we'll have the pleasure of hearing from Dr. Alex Bennett. Dr. Bennett specializes in community-engaged, interdisciplinary, mixed methods research to address drug overdose, infectious disease, and other drug-related harms. He has focused on a broad cross-section of at-risk populations, including military veterans and people who use and/or inject drugs. Dr. Bennett has been involved with substance use research and overdose prevention for over 25 years, and we're grateful to have him with us. Last but certainly not least, we have Miss Samantha Sam O'Neill, who is a PH candidate. Yay, right? In her role, she facilitates community training on mental health and suicide and leads an intervention work group on addressing community suicide deaths by hanging. She is a doctoral candidate at Palo Alto University, obtaining her PhD in clinical psychology. Her dissertation aims to understand the lived experience of those affected by suicide attempts, deaths, and suicide by hanging via one-on-one interviews. We are so grateful to have this esteemed panel to share their knowledge, their experience, and their expertise with us to learn more about how we can reduce suicide deaths. And with that, I'm going to go ahead and turn the floor over to Dr. Larson to talk to us about how he worked to identify data related to preventing suicides in public places. All right. Let's see. Dr. Larson, I'm going to give you the floor.
Good morning, good afternoon, wherever you're joining from today. My name is Mark Larson. I'm an Associate Professor at the Centre for Big Data Research in Health at the University of New South Wales in Sydney, and also an Honorary Associate Professorial Fellow at the Black Dog Institute, also at UNSW. Thank you for the opportunity to record this presentation today after the technical difficulties we had on the day of the meeting. And before I continue, I'd like to take a moment to acknowledge the Gadigal people of the Eora Nation as the traditional custodians of the land from which I'm joining you today, and I pay my respect to the elders, past, present, and emerging. I also want to flag research funding that I've received as an investigator on work related to this topic, as well as membership of an advisory group convened by Lifeline Australia, which I'll mention during the presentation as well. So it's quite hard to find reliable, consistent data about suicides in public places. But we know from a report by the wonderful Jane Parkis's group at the University of Melbourne, in the Australian context, approximately 30% of all suicides occur in a public location, and about 3% of suicides are at frequently used locations, sometimes colloquially known as hotspots. And there's some evidence from a study looking at a single county in England that a similar rate of about 30% of suicides there were also in a public place. What we are able to access a little bit more readily is from databases about the causes of death. What are the most frequently used lethal means used in suicides? And this is plotting those rates of frequently used means across 5 countries in the global north, including Australia and the USA. And while we do see some variation in the frequency of use of specific means, we do see that there is a fair degree of consistency in which means are most frequently used. And we see that jumping, that's jumping from a high place, or jumping in front of a moving vehicle or object, is consistently the 3rd or 4th most frequently used means. And of course, suicide in a public place or suicide by jumping isn't synonymous, but there is some degree of overlap in these methods. And suicides by this method or in public locations is a particular focus for intervention efforts, because we know these can have disproportionate impact on bystanders, members of the community, witnesses, first responders who are at the scene. And there's also the possibility of contagion effects, particularly where stories may gain notoriety in the media that may sort of make the location more frequently used for suicide. So what can be done to prevent these? So in our review, again by Jane Parkes's group, we found that in addition to responsible media reporting guidelines, there are 3 broad categories of interventions that can be used at frequently used locations. The first is physically restricting access to means, for example through the use of fences, safety nets, or platform screen doors on railway platforms. The secondary category is encouraging help seeking, for example through the installation of help seeking signage or the installation of crisis telephone hotlines. And the third category is increasing the likelihood of third-party intervention, for example through the use of CCTV cameras or police or security patrols at the site. And these interventions can be used in combination. They don't have to be used in isolation. For example, one of the locations in Australia, a cliffside park location, actually implemented a number of these strategies in parallel, including restricting access to means through the use of climb-proof fencing, which is carved inwards, so it's hard to climb over the fence towards the cliff, but if you are on the wrong side, it's easier to climb back to safety. There's the installation of help-seeking signs and dedicated crisis call boxes to get through to the lifeline servers. And they also installed CCTV cameras, which I'll talk about a little bit later, as well as generally opened up the site, make it more of a parkland so that there would be more locals, more tourists in the site, so there's some more chance of interacting with someone. So these strategies can be used together or in isolation, but what's the evidence for how well they work? So this is quite a complex diagram. We won't go through all the details, but the National Institute for Clinical Health and Excellence in the UK have conducted a series of evidence synthesis or evidence reviews looking at what works. And this complicated diagram is looking at the evidence of physical barriers. And really what we want to focus on is the location of these diamonds relative to the highlighted vertical line. And if these diamonds are to the left of the line, as they are here, that means that there's evidence that those approaches reduce suicides. So here the 4 diamonds are showing that interventions at jump sites overall are effective. The installation of platform screen doors are effective, and safety nets are also effective, although there may only be a couple of studies for each of those. So overall, there is evidence that physically restricting access to the jump site is effective. The second part of the review looked at the evidence of encouraging help seeking, and here it's a little bit more mixed. The diamond here is actually straddling that vertical line, which indicates that we don't have conclusive evidence whether it is effective or not. So this is perhaps not quite as an effective strategy as physical restriction of access to means. And then for the third category, the use of surveillance, again we see the diamond is to the left of that vertical line, so there's evidence that surveillance can reduce suicides at these locations. So a question that frequently comes up is if you try and intervene or prevent suicides at one location, does that just move or displace the problem to another location? And it's actually quite hard to gather conclusive evidence for this. We did look at what's happening at that particular cliff site in Sydney, and what we see is on the left, it's the pre-intervention period, and on the right we have the post-intervention period, with the different colours representing the different frequency of suicides at the location. And you see it's actually quite hard to see a clear change in that distribution or pattern over time. And if we try and look at this as trend data, when we look at the trends, we see actually on a year-to-year basis, the number of deaths does jump around quite a lot. So it's actually hard to determine whether those trends are generally going up, generally going down, or holding steady. So at these sites, at the cliffs, it's particularly hard to determine what's happening. Overall, we do see if there's means restriction activities at a population level, not particularly associated with individual specific locations, but population level approaches does seem to reduce the rate of suicide in a location or in a country. As I said, the site-specific impacts are harder to assess. There has been a focus on bridges in particular rather than cliffs, and what this seems to be showing is that there may be a numerical increase in suicides at other locations, but this isn't statistically significant. So again, we're not really sure or confident whether this displacement is happening. But the thinking overall is that through installing means restriction interventions at a site, there may be some degree of displacement, but we're likely to see an overall reduction in suicides. And this is related to the idea of if you can help someone through that particular moment of crisis, then the thoughts of suicide may pass. So in addition to these sort of quite physical specific interventions, there's a number of other approaches that are being looked at internationally. One such approach here in Australia has been coordinated by Lifeline, where they've really taken a multi-sector, multi-stakeholder approach to bring together local communities, local councils, first responders, health services, and community organisations to look at what's happening at a particular location or in a community and find comprehensive strategies that would work at those particular locations. And that has had a number of successes, as indicated in this infographic. And I'll include a link to this information on the last slide so you can follow up with more information if that would be useful for your own communities. In the UK, at a particular frequently used cliff site there's actually a chaplaincy team who are on site and patrol the cliff looking for and supporting people who may be in distress. This is, I guess, related to the idea of security patrols or police patrols, but not in sort of quite such a formal first responder style, more of a community-based approach to helping people at these locations. Also in the UK, the Samaritans, in partnership with academics and the railway network, have looked at the Small Talk Saves Lives campaign, where this is really a public awareness campaign so that people can feel more confident or able to start a conversation with someone who may be in distress or in crisis, to provide that moment of connection that can really help someone during those moments. In Australia as well, a partnership with Lifeline and TrackSafe, a railway safety peak body, extended this with the idea of a digital advertising, digital billboard approach, where the Pause Call Be Heard campaign included a guided breathing exercise that was displayed in railway stations and other locations. I'll play this to you now if it works for the recording. So that simple activity, if someone is in distress on a platform, that may be able to help them through that moment. So I mentioned as well the use of CCTV as an approach which can be used at these locations, and just mention briefly some of the research I'm currently undertaking at a particular cliff site again. And with the CCTV cameras they have installed, hopefully it's clear in this diagram, but beyond the physical fence line, there are two lines drawn on the scene which represent virtual fences. And if a person is detected crossing through these virtual fences, that raises an alarm at a control centre. A security operator can log in, see if there is actually someone over the fence, and initiate a police call-out and a police response if it's needed. And what has been found when police have retrospectively looked at the footage, quite often people have been quite visibly in distress for quite an extended period of time before climbing the fence. So the research project we're undertaking is looking at whether it's possible to identify some of those behaviours prior to climbing the fence, and whether they themselves can be detected. So we're using a set of quite simple video analytics. For example, here is showing trying to identify where in a scene a person is, represented by the bounding box or the rectangle drawn around a person. And from another scene here, this is really sort of then extending that to try and understand how people are moving through space, to get an indication of whether people are pacing backwards and forwards along the fence line, whether someone might be standing at one particular spot of the fence for a significant period of time, or whether there are actually more subtle cues which may also be identifiable. And obviously we're aware the use of CCTV cameras can be a sensitive topic, so we've also explored the public's perceptions or attitudes towards this sort of research for suicide prevention, and we found that there's actually, in the Australian context at least, quite strong support for the use of this approach in the suicide prevention space. There is also slightly stronger support amongst those people with lived experience for this sort of approach. So people who have experience of suicidality or who may have been bereaved by suicide. So this project is ongoing. We've got a paper about the acceptability, which is in press, and hopefully sort of delves into these details further, sort of with more of a qualitative understanding of what's happening as well. So I just want to leave you now with links to 3 resources. One is the Lifeline site intervention work that I mentioned earlier. It's possible to connect in and see what sort of resources are available that can be used with your communities. The second is the evidence synthesis undertaken by NICE in the UK. And this has a lot more details about what the research evidence is and what sort of strategies can be implemented. And the third link is a bit more of an academic paper, a meta-analysis looking specifically at the prevention of suicide by jumping and what sort of interventions work in isolation and best. Thank you for your time, and if you have any other questions, please feel free to reach out to me at the email address shown here. Thank you.
All right. So we are here, the crisis of accidental and traditional overdose among military veterans. Um, Dr. Bennett, if you are ready, I will hand the floor over to you. You should be able to control.
Okay. Good afternoon, evening, everyone. And yeah, thanks for inviting me and letting us present some of our work today. So today I'm going to be talking about veterans' health and drug overdose, really in the context of our research and outreach over the past decade. Can people hear me, Jasper? Can you hear me, Jasper? Okay, good. So, my work, I've been working on overdose for about 25 years. My work with veterans began around 2010. At the time when veterans' overdose mortality rate was close to twice that of the general population. POs were widely used to manage pain, and heroin was increasingly becoming a cheaper alternative for pain management needs. I also briefly, before I move too far, I want to acknowledge NIDA for their funding, and I want to also acknowledge all the veterans who really provide their valuable input in our work. Okay, so today I'm going to start by providing a bit of a background on the evolution and magnitude of the crisis of drug overdose. I'm going to discuss the risk factors for drug overdose and some of the challenges of classifying them as intentional, suicide, or accidental. I will then discuss some of our work with veterans in New York City, which underscores the need to consider both accidental and intentional overdose in the context of veterans' challenges, their health needs, and programs designed to assist them and their families. I'm going to end with some recommendations that may inform efforts to mitigate the tide of drug-related morbidity and mortality. So drug overdose deaths in the United States have really reached crisis levels, setting new national records each year. COVID only really made matters much worse, with so much additional mortality alongside the many psychological, social, and economic challenges many people, including veterans, already faced. Over 170,000 people died from drug overdose in the 12-month period ending August 2022, something unprecedented historically. Estimates are that the crisis is continuing, with similar levels of mortality predicted for 2023. Now, looking at the rise in drug overdoses over the past few decades, this chart shows a steady rise in mortality from the late 1990s, one that began earlier in the decade, coinciding with the proliferation of very strong prescription opioids, widely prescribed liberally for moderate and severe pain. This trend continued through the 2000s as the overdose mortality rate climbed, in part due to POs and higher purity heroin that some people started using as a cheaper and more accessible alternative to very expensive POs that were becoming harder to obtain. By about 2013-14, the overdose rate accelerated as more overdoses were involving very strong synthetic opioids, especially fentanyl. You probably have heard about fentanyl by now. It's in the newspapers, on the news stories. It's the most synthetic opioid most associated with overdose, and it's found in the drug supply throughout the United States. It's a powerful opioid routinely used in human medicine, about 50 to 100 times more potent than morphine. It's often used to treat post-surgical and cancer pain. It's short-acting with a rapid onset, meaning an overdose can happen much quicker than traditionally with prescription opioids like an Oxycontin or heroin. It also requires people who are dependent to use much more often. So someone who might be injecting 5 times a day might start injecting 10 times a day. So it really began to appear in large quantities as illegally manufactured fentanyl in 2013. Often mixed with heroin and in fake pills, it's now the primary drug causing overdoses. And in some ways, it's really the equalizer of sorts. Sniffing can be as risky as injecting. So you can see the real spike in this chart of the gray line of fentanyl overdoses. And we're also starting to see an increase in psychostimulant, methamphetamine, and oftentimes mixed with fentanyl, as well as cocaine. So looking at this larger overdose deaths, mortality, the point I want to make is about 5 to 7% of these overdose deaths are recorded as intentional, okay? About 5 to 7 intentional. But because it can be difficult to determine whether overdose deaths are intentional, the actual numbers of suicides are likely much, much higher. And I want to briefly touch on this. So there are wide-ranging estimates of how many of these overdoses are accidental or intentional. In some overdoses, and in some overdoses, it's really impossible to determine intent. And this is very important in terms of why we need to consider risk factors for both accidental and intentional overdoses and develop interventions to address both. In terms of some of the challenges of classification, if someone dies without a doctor present, a local medical examiner or coroner will be the one who decides how they died and if it was suicidal or accidental. Every state conducts death investigations differently. So death records are not unified nationally, and only about 16 states in the District of Columbia have statewide death record systems. The others are local and can involve elected coroners or sheriffs. So there's really not a good standardized policy, okay? The system is overwhelmed too, due to the rise in drug-related deaths that we just seen, and also COVID. So extensive investigations are not always possible. If a case is undetermined, it gets kicked up to the forensic pathologist for a full autopsy. If the decision is acute drug toxicity, accidental death, then the case is done without an autopsy. So this all said, there are estimates that 10 to 15% of suicides are misclassified as accidental overdoses. So that number that we saw greatly increases in terms of intent, right? In terms of establishing suicidal intent, coroner and medical examiners must have explicit verbal or nonverbal expression of intent. Stigma, right? Stigma of addiction, shame, family shame, resources, and insurance may all influence decisions to influence classification decisions. Some certifiers require a suicide note to certify death as suicide, yet only about 1/3 of persons who commit suicide leave such notes. So looking at suicide, again, over time, we see a real similar rising trend from the early 2000s with suicide death, all causes, for the general population and for the veteran population, with slight declines in 2019, 2020. In terms of the age-adjusted rate, it climbed significantly for both men and women veterans over this time period. Climbed to over 40 per 100,000 for men at the peak in 2018 before a slight decline. And there's an increase again by 2021. So these are going back up. A similar pattern was observed for women, with an age-adjusted rate increasing from close to 10 per 100,000 in 2001 to 20 per 100,000 in 2018, before the decline. Now here I wanted to point out that there are, in terms of who's committing suicide and overdosing, the trends in suicide observed among veterans and non-veterans is similar in some ways with the accidental overdose data. Some of the biggest increases in suicide and accidental overdose between 2011 and 2020 are among Blacks, Hispanics, American Indian, Alaskan Natives, as well as younger people, especially ages 12 to 25. For Blacks, the increase was 58.2%. and over 70% for American Indians, okay? That's a very large number. For youth, aged 12 to 17 years old, there was a 58% increase in suicides between 2011 and 2020. Males are dying by accidental and intentional overdose at almost twice the rate as females. Now, the means of suicide varies too. Looking at, now these are overall, so these are veterans and non-veterans. These are female suicides by means of death. And we see here that really drug poisoning is the main means of suicide. For females, drug poisoning has been the most common, and then by about 2014, this is alongside firearms and suffocation. For men, it's slightly different. For men, by far the most common means of suicide has been firearms, followed by suffocation and poisoning. And we see a slight trend, a downward trend in poisoning, which I'll talk about in a second. And so here here's a visual representation of veterans and the means of suicide. And here again, we see way up above our firearms, but not insignificant, we have suicides and suffocation down below too. And here, this shows about what percent of a suicide is a firearm versus drug poisoning versus suffocation. And you do see a slight decline over time in drug poisoning. And I might speculate that part of this is due to prescription drug monitoring programs, fewer drugs out there, and greater awareness in terms of some of the the risk associated with substance use. So I want to turn a little bit now to risk factors. And again, I suggest that risk factors for suicide and accidental overdose overlap in many ways. In general, the drivers of the overdose crisis have been framed as supply or demand. From the supply perspective, there's more availability of drugs, more supply, right? And that has resulted in more suicides and more overdoses. So with more POs and now fentanyl, there's a resulting more consumption. From a demand perspective, we look at rising inequality, more mental health challenges, and what recent scholarship has labeled deaths of despair, increasing mortality due to declining fortune, resulting in rising drug use, more alcohol use as a means to cope. So with more socioeconomic mental health struggles, there is more opioid use as a form of coping and self-medication. Because so much of the opioid use is in the illicit drug supply, and now we have fentanyl, which is unregulated, there's really no safe supply. So I think, we're going to see even more deaths. This is really, really concerning. It takes very little fentanyl to overdose. Now, in terms of the literature and our work with veterans, it seems that there is both supply and demand forces at play in terms of the increase of suicides amongst veterans. Many veterans have untreated physical and mental health concerns, including PTSD, mood disorders, trauma including pre-service, service, and readjustment that elevate risk for overdose. There's a very clear link between mental health challenges and suicide. Veterans face a host of social and economic struggles as well that may exacerbate risk for overdose. Stigma, debt, social isolation, unstable housing, unemployment, poverty are all things that many veterans have to contend with. Many veterans are disconnected from services. Less than 50% utilize the VA. And there's a clear link between suicide and substance use disorder and overdose. Finally, in terms of risk factors, I think there's a need all these really need to be thought about as an ongoing dynamic interaction among multiple life domains, including physiological, psychological, and social and structural factors that create a complex of risk in which overdose, accidental or intentional, may very well be the outcome. And here I just want to draw your attention to the fact that over 1/2 of suicide deaths among veterans were with veterans who had comorbidities, including mental health or substance use disorder. And you can see that right at the top there. So this brings us to the next part of my presentation, which is really based on some of our work that we've been working on really since about 2010 through 2022, really to better understand and prevent overdose, both intentional and accidental. As I mentioned, our work began in the early 2000s when the overdose rate amongst veterans was about twice the general population. We wanted to learn about risk for overdose among OEF, OIF veterans, many of whom had just returned or separated and had experienced liberal PO prescribing and encountered many challenges readjusting to life post-service. We wanted to understand how, over time, changing physiological, psychological, and social factors might influence substance use and overdose risk. Our team included veterans and non-veterans, and we wanted to really listen and learn from veterans and the agencies that serve them. So one of the first things that we did is we established a community advisory board with many local agencies, including the Departments of Health, Black Veterans for Social Justice, Lantern Project, Drug Policy Alliance, Harm Reduction Coalition. We had focus groups with female veterans, male veterans, homeless veterans, veterans attached to college. Again, from all these different perspectives, we were really trying to listen and learn what is associated with this opioid misuse, the suicidal intent, and the challenges that veterans are facing. We also started to do overdose education and naloxone distribution. So early on, by about 2014-15, we were actually giving veterans who we worked with naloxone, in a sense enabling them to be responders to help other veterans who might have an overdose. And really, this is all about listening, learning, collaborating, and developing partnerships. So the study I'm going to talk about right now was called Opioid Misuse and Overdose Risk Patterns Amongst Recent Veterans, and it involved veterans who served in Operation Iraqi Freedom and Operation Enduring Freedom. It was a 2-year prospective cohort design, and we enrolled about 200 veterans. We used venue-based sampling and chain referrals. All the veterans whom we enrolled were currently using heroin, prescription opioids, or methadone in the past 30 days. It was a community sample, okay, chain referral. Many, close to about 50%, were not connected to the VA healthcare. And so we met with the veterans and we gathered information at baseline face-to-face and then web-based information over time for 24 months. Okay, so again, we had a survey face-to-face at baseline, and then over 24 months of time, we were trying to learn more about each month about overdose risk behaviors, adherence, alternative administration, solitary use, mixing drugs, periods of abstinence. We're also trying to learn about recent overdose experiences, period preceding overdose, alongside depression, PTSD, TBI, suicide ideation, treatment, social factors, and life events. We also conducted qualitative quarterly in-depth interviews with about 36 veterans and another set of interviews with veterans who experienced an overdose. And as I had mentioned, we started giving naloxone, the opioid overdose reversal medication, directly to veterans. And so here I just show basically our overdose risk behavior scale, and you can see we, really we're looking at a lot of questions. These are questions that people asked, that people answered every month for about 24 months. And so we can see how, again, changes in pain, mental health, or social events might have increased or been protective against overdose risk behaviors. There's really very little in the literature to assess this. And so, we developed this overdose risk behavior scale for field use and research. And, basically the higher the score, the more overdose risk behaviors and the more risk. So, ideally you would not engage in any of these risk behaviors, but some people could engage in upwards of 15 to 20. And here you can see some of the, the most common overdose risk behaviors. And I think concerning is really how using alone is such an important thing for veterans. Using alone, using off script, using for sleep, as well as using mixing drugs. And one of the big risk factors for overdose is mixing opioids with alcohol and oftentimes benzodiazepines. And here I just wanted to visually show how dynamic substance use patterns for one individual can be over 24 months. So here we had one participant, wonderful fella, and really you can just see the ups and downs of heroin going up, prescription opioids going up and down, marijuana, alcohol. And all of these ups and downs are in relationship to changes in his treatment. He got a divorce, right? Big risk factor. Social factors, losing his apartment. All of these things influence the overdose risk behavior. And so now I'm just going to sort of sum up some of the key findings from our study, which I think are things that we can all really focus on, and really how significant the associations are between physiological, psychological, and social factors and engagement in overdose risk behaviors. The worse things are for these veterans psychologically, physiologically, and socially, the more overdose risk behaviors they engage in. So being unsheltered or in a homeless shelter is significantly associated with overdose risk behaviors. Pain severity, pain interference, and moderate severe depression all positively associated with overdose risk behaviors. Family problems like divorce, economic stressors, unemployment, death of serious loved ones, legal and justice system encounters, and housing problems are all positively associated with overdose risk behaviors. Longitudinally, over time, over the 24 months, we found ORB scores were positively associated with pain severity and interference, suicide ideation, and depression. So thinking about suicide, this really complicates or muddies the accidental intentional dichotomy. For some people, things just are not going well, and misuse can very easily translate into an overdose. And so again, I think what this points to is the need to understand veterans' challenges holistically and comprehensively. And we need to address veterans' physiological, psychological, and social challenges. Our qualitative data sheds additional light on some of this, the fuzziness surrounding the distinction between intentional and accidental overdose. As I said, as part of this project, we interviewed veterans who had experienced an overdose to learn more about their overdose experiences, if they involved intent or were accidental, and again, to try to help develop our overdose risk behavior scale and measures. The first quote highlights this, the challenges of readjustment faced by PC, a 34-year-old Army veteran who had overdosed since the separation from the military, and he speaks to expectations and shame of not making it. He says, When you come back, you're almost viewed as lower than when you left, because it's like, how'd you mess up a free place to live? All this money and travel. What they don't realize is that it's the model of the military, that it's that you give 100 and they take back 99. Nothing is free. It's almost worse than living a regular life, because you're not expected to get help. You're not expected to get help. You're expected just to figure it out. As a soldier, your whole mentality is just figure out and get her done. You're almost looked at like a leech. If you come home not a war hero without a new car and a nice house, you're viewed as a fuck up. You know, the military seems appealing in the hood because it seems like an easy way of life. It's not an easy way out, and it's not an easy way back in. And here we have themes of pain, injury, and sort of the iatrogenic progression to dependence. We have another veteran who was living in a veteran residence at the time of the interview, having hurt his knee while serving, and he recently separated and recently overdosed. That's the main problem. He says, if you're like me, disabled, you can't work, you don't have a home or apartment, you're always in pain, you're not making money, you're partying, you don't have a life. Bored, drinking drugs. I can see how people overdose and commit suicide or want to do more drugs, drink, and other things because you don't have anything else. I was in the military for 6 years. I've done deployments. I've slept in the mud, so it shouldn't be this hard for me coming back here. So there's a lot to unpackage here with Jared's account, in which it moves between sort of stereotypically presented recreational drug use into a more nuanced discussion of self-medication and coping. You know, society often frames mentally unstably housed veterans as deviants and undeserving, but what our qualitative interview shows is that after military service, these veterans cared immensely about others and society in general, but faced almost insurmountable barriers to achieving their goals. They blame themselves for their failure, not the larger social and structural inequalities they have to endure. This is often compounded by mental health concerns and SUD concerns, substance use disorder concerns, as well as a lethal drug supply, right? A very lethal drug supply with fentanyl that greatly increases the potential for drug overdose and suicide. The lack of meaningful employment and social relationships described, as well as his professed understanding of how such conditions can lead to suicidality, point toward a pressing need to investigate further not just common mental health diagnoses, but a more diffuse experience of social enemy and isolation among veterans and how to create meaningful opportunity. And I want to note here that it's important that the majority of the participants who we interviewed, about 30 out of 36, who had experienced an overdose, many unstably housed and unemployed at the time of the interview, characterized their overdoses as rooted as a general sense of apathy, somewhat passive, and a desire to temporarily escape life circumstances that had become difficult or unmanageable due to housing, employment, relationships, legal, and financial challenges. So I just want to talk a little bit about some of our findings really that we've gathered over the past decade and from this research and our outreach with veterans, is that with regard to overdose events, suicidal intent might be understood as part of a continuum of intentionality rather than as one half of an accidental intentional dichotomy. It may be more valuable to view overdose risk as emerging from a dynamic process of events over the life course that leads to and influences proximal conditions relating to veterans' current substance use that can precipitate an overdose. For some veterans, it appears that apathy, anomie, and especially when combined with severe physical and or psychological pain and social isolation, can lead to a flirting with death scenario. Accordingly, a rigidly dichotomizing perspective focused on identifying those actively seeking to commit suicide may have failed to identify those whose apathy or cavalier attitudes towards danger also effectively place them at risk of overdose. Findings reinforce the need for more comprehensive and holistic understandings of the interlinked biological, psychological, and social precipitants of opioid-involved overdose amongst the veteran population, and the role of both background and proximal conditions in producing overdose risk. And so some of the things that we recommend, there's a lot, but just briefly here, is really improving community access to low barrier, community-based substance use and mental health treatment. Targeted opioid safety and overdose prevention programs are needed to minimize drug-related harms among the veteran population. A co-location of mental health services, pain management, medications for opioid use disorder, and harm reduction services needed. Because many veterans do not utilize the VA, community-based outreach programs should be implemented to reach the segment of the veteran population that is disconnected from veteran services, many of whom are also in need of stable housing, education, and meaningful employment. There's clearly a need for ongoing drug-related education among veterans. Veterans we've worked with often initiate opioid use for medical reasons without a full understanding of the nature of the substance being used and its inherent risks. And I think it's also important to address the stigma of being dependent on opioids and the shame regarding treatment seeking. This heightened sense of masculinity is something we've seen quite a lot. Destigmatizing substance use treatment, particularly in the current era of heightened monitoring and concern regarding public health crisis of opiate misuse and overdose, is a task that must be undertaken society-wide. At a very basic level, overdose education and naloxone distribution programs should be universally available to opioid-using veterans, their peers, and their families. Peer outreach has proved an effective intervention modality for veterans in some contexts, and when conducted by those with firsthand experience of opioid misuse, stands to aid in destigmatizing treatment seeking and connecting socially marginalized veterans to services, including methadone, buprenorphine, and harm reduction programs. Increasing evidence also indicates that people who use heroin assume much less risk of overdose when using substances in monitored context, such as safe consumption sites where they can be monitored by trained staff after using opioids. These spaces can also offer linkage to medications for opioid use disorder and other forms of treatment, such as CBT and other forms of MOUD. And finally, just before I end here, I know we're about out of time, and I wanted to do actually a sort of an overdose prevention training, but I think it's very important that everyone has naloxone really in their medicine cabinet, in their backpack, in their cars. If you do not have naloxone, do not know how to get it, please email me, and I can connect you with someone in your local community who can help you get naloxone. It's a lifesaver. It's a safe medication that reverses opioid overdose and blocks opioids for about 30 to 90 minutes. It works on all opioids, including fentanyl. It's not a controlled substance. There's no known negative effects and does no harm. It's well studied and there's no potential for abuse. It can wake someone up for an overdose in minutes. And thank you.
All right, thank you so much for that, Dr. Bennett. A wealth of information for us to take back and digest. You guys, please do list your questions in the chat and we will get those answered and addressed following our final presenter. Now I'm gonna go ahead and hand things over to Ms. O'Neill to talk about the work that they're doing in her respective community.
Hi, folks. Thanks everyone for being here today. All right, now I have access to the slides. Awesome. Thank you. So we're gonna get through as much as we can as quickly as possible so I can show you our outputs of what we've actually made. Okay, so why we address suicide by hanging is a question we get a lot. And the reason that we focused about it in Santa Clara County in California is because in our county, suicide by hanging accounts for about 40% of suicides between 2018 to 2022. And that number is even higher now if we include the 2023 death data that we have so far. Research, policy, and practice has yet to tackle hanging means in community settings because most of the research that has been done is focusing on institutional settings. So that's a prison or a hospital or a psychiatric ward, places that it's much easier to do means restriction. But in the community, we can't restrict every possible means that someone can use to die by suicide by hanging. So because we can't use means restriction, we need to take a different suicide intervention approach to address this method in our communities. So this is the progress to date of what we've done since January 2021. I'll go through this relatively quickly, just emphasizing the blue bits here. So we started off with a clinical roundtable of having folks that were community experts, clinicians, people who have been impacted by suicide deaths by hanging, having a roundtable get together of what can we do to address suicide by hanging in our communities in suicide prevention strategies. And then literature reviews were conducted by myself and 2 others in our group. And there was a discussion amongst our larger group, which is the Suicide Prevention Oversight Committee, to talk about the findings from that literature review and the conclusions from that roundtable, to go over initial discussions and recommendations so that we can have a final clinical roundtable to go over those recommendations and finalize what we do recommend for addressing suicide by hanging in the community. And then from that list, recommendation list, part of that was including education. And so we focused on that education piece by creating and disseminating brochures, which I'll get to later in my presentation. And those were finalized and printed this year. And then I presented at the American Association of Suicidology conference with these brochures. And we've also created a fact sheet for 988 responders to educate them about suicide by hanging and who's at risk, which I will also show to you all. So just firstly, some agreed upon concepts is that ligature restriction is very difficult, if not impossible. Very little research exists about suicide by hanging and addressing it in community settings. So we need to take a broader approach of how we could do this because means restriction is not possible or nearly impossible. There is no one-size-fits-all approach. And creating messaging for the general community is a complicated process. We want to avoid, like as always, putting ideas into people's heads and sensationalizing suicide or the information getting into the hands of someone who is already feeling suicidal. So these are all things that we want to take into account when coming up with a different alternative to means restriction for suicide prevention strategies. So I'm going to go over bits and pieces from our literature review because there have been minimal reviews about what has been suggested to address community deaths by hanging. So firstly, people have suggested decreasing cognitive access. And what cognitive access is how accessible something is in someone's mind. So the theory behind that is that the more people are exposed to something, the more easily they're going to come up with it when they are thinking about whatever it may be. So in the case of this, if they're having suicidal thoughts and they hear about suicide by hanging very often, or they know about it, they see it in social media, they see it in movies, that might come to their minds a lot faster than another method of suicide. And then part of that is monitoring the internet and the media. So safe messaging does work. So reducing the portrayal of fictional suicides by hanging and the overall reporting of hanging suicides reduces sensationalism and does reduce that cognitive access. It also decreases the acceptability of the suicide of this method of suicide. And just showing that safe messaging does work in general, that reducing media reporting of suicide deaths at bridge hotspots help demystify the site and decrease jumps in those surrounding areas. So just showing that with another method, monitoring media has been helpful, so that same thing can be applied to suicide by hanging. So the recommendations here are limiting access of information on technicalities of hanging from the media. So there are things out there of how to correctly attempt suicide by hanging, how to do it with step-by-step information. So limiting access to that, because there has been studies shown that people looked up how to attempt suicide by hanging prior to their suicide attempt. And for example, Korea introduced some media guidelines about what can be on the internet and regarding suicide, and that has been successful in reducing some suicides there. Another suggestion, this one's a little more difficult, is changing the engineering of household items. So for example, ceiling fans and making them as non-weight bearing as possible is a suggestion that's been made. Using collapsible fittings in closets and lowering anchor points. An anchor point is something that someone can use to put a ligature on, so you can think of it as a ligature point. And then using accordion doors or curtains to minimize risk around windows and doors. This would obviously be a very difficult feat to change every ceiling fan, every collapsible fitting in a closet, all around the world, but these are suggestions that have been made. There's also a note about being cautious about the extensive assessment about ligatures when doing a suicide assessment. You don't want to do a whole, 2-3 page list of everything that people can use to hang themselves, but instead go for the common methods that people already have accessible, that cognitive access in their mind, so as to avoid putting new ideas into people's heads. Because there was a study that showed that providers that did go through a long, extensive list gave some of those people an additional idea of, oh, I can use this to attempt suicide. And the next one is just involving collaterals. So this kind of gets into the education piece. So just thinking about general suicide prevention strategies of providing education already reduces stigma, mental illness stigma. And then people who are knowledgeable about how to reduce risk in general in our community will help be the community eyes and ears so that they can address risk within their community, even if a provider isn't there. And so assuming that collaterals can be prevention, family members and those close to the suicidal person can be trained in how to restrict opportunities at home. This applies to any method, not just suicide by hanging. And for example, there was a study about the mental health environment of care checklist that's in inpatient units that the VA has that could be adapted for collaterals as a suggestion people have made in the past. Another one is demystifying and disproving myths. So there is some misconceptions about hanging that have been proven as the reason that people choose that method. So people believe that it can be quick, certain, painless, and doesn't leave a harrowing body, and considering it easy to access and simple to perform. But those who chose to not use suicide by hanging as their suicide attempt method pretty much thought all the opposite of those things. So they saw it as slow, painful, and messy. And that's the accuracy of that it's not a quick, certain, painless, and not leaving a grotesque image. And so these misconceptions are really influential. So trying to get at demystifying those misconceptions could be helpful. But there is that concern of not wanting to facilitate an attempt by sharing these misconceptions. So instead, people have suggested focusing on the strong emotions evoked by attempt from a family or loved ones, focusing on the processes, consequences of hanging, and introducing the awareness of the possibility of neurological impairment on survival as a way to demystify those myths. And these are just some additional characteristics from literature reviews. So people who use ligatures, I mean, everybody's using it. That's why it's the #1 method in our county, which is true for a lot of places. But mostly youth and young adults and non-white and non-Black groups are using suicide by hanging. It's most likely to occur in late afternoon or evening hours. It most likely occurs in people's place of residence, mostly indoors, but it can happen outdoors. Certain behavioral, social, physical, personal factors can be warning signs and have a higher risk with ligature usage, as with all methods. And ligatures are used frequently among both females and males, among married and single individuals, and ligatures are commonly used among veterans. And more research is needed on LGBTQ folks because there simply isn't enough data to come up with conclusions for this population. So our recommendations as a list to provide to you all of what we came up with of some good next steps is coming up with educational pieces. So first, that is these brochures, which I'll be talking about. That also includes a training. So similar to a CALM training, counseling on access to lethal means, it could be a training on suicide by hanging specifically. Going about assessments and safety planning to ensure at least common methods are included. And then some other considerations that we came up with is using our own existing materials, including our own data. How do we counter misconceptions, which I was talking about earlier, and then acknowledging throughout all of this the limitations of means restriction for this method. We also came up with expanding our efforts to other providers. So other than clinicians, other than people in mental health professions, it could be faith community members, family, friends, staff in school settings. We also considered going back to those controlled environments where most research is being done, just to reinforce and support assertive and comprehensive access restriction policies. And then we noticed that there's just simply not enough research on this topic, so further data analysis and data gathering is needed to better understand this phenomenon. So things that we put, parking lot ideas of things we can get back to does include those structural changes. So there's bigger things about like building codes, ceiling fans, collapsible fittings. Another one is monitoring of knowing when people can consider hospitalization for their loved one because people cannot be monitored 24/7. And then that same issue of countering public misconceptions while still being sensitive. And addressing misinformation on message boards because, yeah, the internet is very, very vast. So being able to clean all that up would be very difficult, but it is a great recommendation that has been made. Okay, so now I'm going to, if I can share my screen, I'm going to share the brochures with y'all. It says host disabled participant screen sharing.
Should be all set to give it a try now.
Okay. Let's see. Okay. Everybody see this okay? Awesome.
Looks good.
Thank you. So this is our caregiver brochure. We made 2 brochures, one for caregiver, one for providers, because there is more information that we wanted to give to providers that is more technical, more statistics focused, more of what they can do in their work to help, whereas what caregivers can do to help their loved ones. So we decided having both those brochures was important. I will say one caveat here is provider brochures for everyone in this meeting. Provider brochures are only for providers. Do not share this with caregivers, but the caregiver brochure can be shared with everybody, anyone in your community. So this is like a trifold brochure, so just keep that in mind. It's not just 2 pages, but it's consistent throughout both brochures. We have a page for resources and the background of what suicide by hanging is. For the caregiver brochure, we kind of go basics of what are common methods, common ligature and ligature points, and then how it affects our community. And then for the middle part of the trifold brochure, we discussed what caregivers can do to reduce risk of suicide by ligature and just suicide in general for their loved ones. So we have a training called Be Sensitive, Be Brave in our community as a way to help caregivers talk about suicide with their loved ones. So we have that included here. We discuss make a safe home environment while acknowledging that not all ligatures and ligature points can be restricted from the home, but common methods can be restricted and thought of. We emphasize the use of a safety plan, and if the loved one doesn't have a safety plan in place, how a caregiver can get that started. And then we included that note of hospitalization, a small note here of just knowing that hospitalization is an option. There are other options, but knowing that 24/7 monitoring is not possible for a loved one. And then we have our suicide warning signs. And so for the provider brochure, it's very similar. It has resources that providers can give to caregivers. It has that similar description of basic definition of what suicide by hanging is, but it also includes some additional information and facts. And then the difference here, it still has the suicide warning signs, but it includes 2 different panels of addressing accessibility through suicide assessment. So having that caveat of we don't want to assess everything, but we want to at least address those common forms and those methods. And then also how providers can talk about ligatures with caregivers so that caregivers are even aware of this as an option. And then finally, we made a fact sheet. Let me zoom out a little so we can see it a little better. We made a fact sheet for our 988 responders in our county, which is basically the provider brochure in a 1-pager. And the difference here is that it includes our county demographics risk factors, so that when people are getting a response, a 988 call, they can kind of look through this and be like, oh, I know these identities of the person that's calling because they've shared it with me. I want to keep suicide by hanging in my mind because this population is higher at risk within our county. And then the rest of the information on here is the same as the provider brochure. And I wanted to share these with y'all because I think it's important to share what we've done, because this is stuff that y'all can adapt to your communities as well. It's not something just for us. This is something it would be awesome if we could all use. So you can take this and make it your own, add your own county demographics, add your own extra tidbits of information, but I think making everything accessible to everybody, and that's affected by suicide by hanging, which is everyone here, would be the best way to start getting this suicide prevention effort out there. And that is everything in my presentation.
Thank you so much. All right. I think it is the time we've been waiting for to discuss questions. If we have any specific questions, please do feel free to unmute yourself and address either of our 3 presenters with questions relative to their presentation. And can you guys see the slides okay?
Yep, looks good, Jason.
Okay. There we go. Let's take a look at the chat. Really helpful information. This is great. Look forward to adapting. Let me scroll up. There was a question early on for Dr. Larson about accessing the research paper that you were discussing in your presentation. Can you let participants know how or where they can access that information?
Sure. Do you know which paper it was in general? I can share the link to it. So I
Yeah,
think I missed the chat when I was disconnected, so I'm not sure which paper it is in particular.
for sure. And Renee, I believe you posed that question. I've scrolled by it. Um, but also just wanted to let you guys know that Dr. Larson has graciously agreed to record his presentation so that we can disseminate it to you all, since we didn't have a chance to hear him due to technical difficulties earlier. So we thank him for that, and we'll be sure to get that out as well in the coming days or weeks. All right, for Dr. Bennett, did participants who weren't connected to VA services provide a reason why they weren't connected?
Mr. Bennett, you're on mute.
Yeah, sorry about that. Yeah, for some people, just perceptions that, or for some female veterans, perceptions that it really was not for them. Older veterans, for others, it was just a lack of, sort of understanding of how to connect and things like that. I think some of this has gotten better since, we did this was like 2014 to 2019. But I would say a host of reasons. Just some people just that it wasn't, for them. Didn't want to utilize. Some people, they had bad experiences. Other people had incredible experiences. So it's not across the board. I mean, I think this is just reflective of who we enrolled, because there's so many. There's such a majority of people who are not connected to the VA, and and for some people there was issues of discharge status, at least perceptions that the discharge status would not enable them to receive VA benefits.
Thank you, Dr. Bennett. All right, for Ms. O'Neill, do you have any data on the effectiveness of one method versus another when we're thinking about prevention methods in me?
Hi. So in terms of other methods of suicide, there is that supported research of, what is helpful, what isn't helpful. Education is usually very helpful. But for suicide by hanging, the efforts that we've done, to my understanding, are one of the first efforts to use any other suicide intervention strategy than means restriction. And because we're using that because we can't restrict everything in our community settings. So there isn't that research yet because this is kind of all that's out there. So while I would love to be like, yes, this is, the best way and we're using this best practice, we're kind of creating the best practice right now. So that is, to be seen.
Sweet, thank you. All right, let's see. We got some resources and information in the chat. If I'm missing any questions, you guys please do feel free to unmute yourselves to address Dr. Lawson, Dr. Bennett, or Ms. O'Neill. All right. Lauren in the chat, I've missed this. Do we have access to the brochures that were created for providers and caregivers regarding hanging? And I do believe we'll get those sent out with the PowerPoint following the session. We'll get those to you guys so you can have access. One question did come through to my box when we're thinking about for Sam, when we're thinking about the are there any gender or age related patterns in suicide by hanging that we should consider in our efforts to address death by suicide? Was there any particular on gender or age in any of your research?
Yeah, so youth for sure and young adults are more likely to use suicide by hanging. But I will say suicide by hanging is being used by everyone, but youth and young adults particularly. And for gender, male and female folks are pretty much equally likely. Male obviously have more deaths in general, so they have suicide by hanging higher when you're looking at male and females, but when you're ratioing it out, there's pretty much equal risk. And for those that are, outside of the binary in terms of gender, there just simply isn't research there. So unknown, but going with a lot of research that's already been out for LGBTQ folks having increased risk of suicide, we can argue that I'm assuming these people are also using suicide by hanging as with anyone else.
All right. One more question, Sam. So, what is your perspective on debunking the myth that hanging is peaceful or painless? How did people go about it? Could it be potentially traumatizing for people to share information that hanging is painful and can cause neurological damage?
Yeah, thank you for that question. And that's the line that we are constantly trying to balance, right? Of not trying to trigger anybody or cause any further harm, but at least provide this information so that these misconceptions aren't out there, so that we have the correct information. So that's something that we're currently trying to juggle. And part of that, the provider brochures have that information about those misconceptions, but the caregiver brochures do not, because that's something that we're still trying to figure out the best way to address that. And so the stuff that we've thought about is like Kevin Hines's story. So having a survivor share their story as a way to impact folks and provide that education at the same time is something that we've been thinking about, but that's also remains to be seen. So if anyone else has really great recommendations, I'd love to hear that too.
Unmuted. Recording and the PowerPoint slides will be disseminated, guys. Thanks everyone for the questions. Yes, really good information. Dr. Larson, you talked or a lot of your work, I know you mentioned actually speaking with veterans, speaking with individuals and peers, right? Is there any insight that you can glean to us as far as how we as community members work to meet their needs? Any, since you're doing this direct work, I think that was the question. Any information we can glean so that we can streamline our efforts that may not have been reported in your presentation?
Sure. I think probably one of the best examples I didn't get the chance to talk about, but will include in the recording in a bit more detail, was some work undertaken by Lifeline, which is the Australian sort of nationwide 24/7 crisis provider service. And they undertook a program of work really looking at suicides in public places. And they formed this advisory group, which included stakeholders from across all different settings. So local municipal councils were represented, police, paramedics, researchers, health service data analysts, and community members as well. And just by bringing everyone together into those early discussions, that sort of really helped shape how to sort of effectively sort of come up with strategies that could help in different communities. So it may not seem like it's immediately streamlining because you're having more discussions involving more people in those early sessions, but I feel that really does help sort of streamline the later process when you have everyone on board and all the buy-in from people. Thanks.
Thank you. Scrolling through the chat, Jess. I wonder if it might be helpful to talk about messaging, i.e., using die by suicide rather than commit. That leaves shame, blame, or praise out of conversations about mental health crises and suicides. And in the work that we do, when we're talking about safe messaging, we do use the term die by suicide rather than commit. Any additional comments from our presenters or subject matter experts on safe messaging related to death by suicide?
I think if I can just add one thing, related to the work with public places. I think there's a change of opinion in sort of referring to places as suicide hotspots as well. I think that sort of suggests or leans into some of the sensationalist language a little bit. It also is a bit of a shorthand, which is, I guess, technically convenient, but we do try to focus on language like frequently used locations or places where suicides are more common, sort of that sort of wording rather than the word hotspot itself.
This is Bill. My question I have is, it's a voluntary act. I mean, this is just a question versus whether it's in pain or whatever it may be. Okay. And I have used VA mental health services. I'm going to admit that right up front. Okay. And have been in some very dark places. Okay. But it's a voluntary act, whereas like death by automotive accident, death by other means like cancer and everything else is something that we consider to be normal and ordinary. Because if we look at it, it's not commit that's really the stigma word, it's suicide. Okay. And when you got a parent that was suicidal and tried 4 times, you kind of know, and you've had a lot of people around you do the same thing, right? To when people that were like second mothers to me when I was young. You look at that act, right? And is it an accident? That's the question I have. And so while we need to have different messaging and centralization or decentralization of it, do we want to call it self-elimination, self-termination, self-something? It's just a question I broach, okay? Because, we look at what we call protective factors. And one of the things the VA lists on their little form is, you have community or religious sources which act as protective factors against suicide, right? That's literally on our VA form, right? When you check into some of the VA mental health programs, okay? Because I filled them out. Again, this is just a question. Because semantically, that's what's happened. Whether it's through pain, now drug overdose, it could be accidental, non-accidental, right? I believe there's a higher rate of death and suicide from drugs, right? I'm part of Group 2 connectedness, and something I realized, I was just at a Project Healing Waters event here in Nebraska, is to see the veterans connect and how that helped them heal, right? And it's that connectedness. And it's that disconnectedness, especially as we saw through the pandemic, that really drives you to get into your head, and you don't feel that connection. You don't feel you got anybody you can reach out to. You don't have anybody you can trust, right? And so one of the first things you got to do is you got to build trust. As a veteran, could I trust the VA? Could I trust them to take my guns? Were they going to lock me up? What are they going to do? But I had to get that trust first. And we got a good VA here in Omaha. So I got that trust and I established that connection. That allowed me to open up. I'm non-combat, but there's still other things that happened. Again, just a query for the experts.
Much appreciated, Mr. Comper, for sharing that and really thinking about how us addressing those protective factors to help save lives for service members, veterans, and their families.
By the way, I read a very interesting work by Lisa Miller. Dr. Lisa Miller, are you familiar with her? It's called The New Science of Spirituality, right? And basically finding meaning in our life. But just look up Lisa Miller, The New Science of Spirituality. Interesting enough, she talks about connection, and she actually interviews a current chief chaplain of the Army, right? And how he connects with soldiers out in the field or even in like the restroom in the Pentagon, right? He'll ask you, how you doing? How's your spirit? right? And stuff like that. And she went through and she looked at some experiences she went through with the Native American tribes, right? The Lakota Sioux, and how they used that to help heal. And I think it's a highly fascinating work, because as you read through the themes there, it comes in through, and you constantly see this thing saying connectedness, how we are connected to this earth, how we're connected because we're running an 8 hertz frequency, right? That's how we connect to this earth, but up for a mile, everything else. Tons of studies, right? And stuff, because, and she's got the fMRIs, the MRIs, NIH grants, everything. I gave it to Chaplain Bruning here in Nebraska, that's part of Group 2 Connectedness. And it was an interesting discussion, because that's what he uses for the young soldiers in the National Guard. They're having marital troubles, looking at drugs, thinking of committing suicide. So I look at Nebraska, and what I'm hoping we can do is we have a lot of ways I think we've not explored for connectedness fully, right? Whether it's like the chaplains learning from the Native American tribes, to us reaching out to leadership, in various communities, in Hispanic communities, the Catholic Church is really strong, right? You look at other communities out west, you've got, the Episcopalian and other churches, but they're the doctors and other people. As we try to develop that connectedness, I'm hoping, I see this as so pivotal. That's how we're going to be able to ask the question done and then get to the lethal means, right? Because if you look at it, like I said, I'll admit, if you can't connect, you aren't going to talk.
And we're grateful for you and for all of the team members that are here today. Some teams have implemented an initiative regarding faith-based initiatives, right? So addressing some of those things. I'm gonna read one comment in the chat, and then this is for future TA, as you're speaking, we can bring back resources on moral injury and chaplain services, and we can also send out those materials. Please let us know what other topics may be of interest to you guys as we continue to do this good work. All right. With that, we are done. Thanks everyone for hanging out a couple of more minutes. Ongoing technical assistance, of course, any upcoming events, there's our link there. Monthly email roundup to stay up to date, subscribe to our listserv. And we just thank you guys for tuning in for this very important topic. And we'll see you guys next time. Take care.
Thank you all. Appreciate your work. You guys are
Thank you, everyone.
superstars.
Wonderful.
Thank you.